Hi all, this is your Dr. House of Pelvis and we'll be discussing the final common pathway. So this is the video you need to come back again and again for you to revise on what are the changes in fetal heart rate during hypoxic stress. And as and when you go through the next 10 to 12 videos on understanding the reasons why the fetal heart rate changes in the particular pattern and the giving the intricate reasons for every small changes that happens here, this video will add more meaning as and when you understand the pathophysiological changes in fetal hypoxia. So you remember the dictum that we need to preserve in hierarchy. We need to preserve the heart first, then the brain, then the kidney, then the body movements. So first I need to have a living baby. That's more important. Then if the baby is living, then I need to have the baby with a good brain. Then if the baby is having good brain, then I need to have the baby to form urine. And once everything is good, then probably the baby can think of going in a 100-meter run race or it can go for a gym. Understand? So this is the logic that we need to keep in mind. So based on that, when we give a stress to the baby, so which I have already discussed, stress is nothing but hypoxia. So when there is hypoxia in baby, the baby heart rate decreases. This is to maintain the positive energy balance. It thinks like, okay, I'll just reduce my heart rate so that the hypoxia is for a transient period hopefully, and I'll just reduce my heart rate, I'll survive the stress, and as soon as my stress is over, I'll come back to normalcy. So if the oxygen is returned back or the stress is removed, the heart rate returns back to normal and the baby is completely fine. This is normal physiological change. Then comes the second part where the stress persists. Now the stress persists. So if the stress persists, see, now I have to maintain oxygen to the heart, I have to maintain oxygen to the brain, I have to maintain to the kidney. The first thing that I'll try to avoid is like, okay, why should I go for a running race now? I'm not having any reason to go on a running race. I don't have to go to gym when I'm not having food to eat also. So as simple as that. So it will try to conserve the body movement. So that will be manifested as loss of body movement. So when I move my body, obviously you know I have tachycardia. So I will not have tachycardia when I don't have my body movements. So there will be loss of acceleration. So normally accelerations are seen in the baby when the baby moves. So when the baby stops moving, there will be manifestation of loss of accelerations in the non-stress stage. So this will be complained by the mother as decreased perception of fetal movement, and we take this complaint so seriously. You know the reason why now, because that is the first step of a persistent stress that the mother is going through, and it could be a microscopic stress also, which we are not exactly seeing. It need not be always a uterine contraction. It can be anything that it causes hypoxia to the baby. So we resuscitate the mother, we give fluids, we do a sonography and see, we do a color Doppler, we try to rule out every possible cause of fetal compromise, and we take a decision accordingly. So this is why loss of fetal movement is a very important factor. Then comes the third point, is when the stress further persists. You have, instead of doing resuscitation, you are allowing the mother, mother is sitting at home, like baby is not moving for 3 days, still sitting at home. Then what happens is, now the baby is panicking. I have given all possible reasons to not move. I'm just staying still so that I can conserve my energy and stay in a positive energy balance. But still you are not removing my stress. So then the baby is fearing, and in fear the hormone that is released is catecholamines. So the catecholamines are released from fetal adrenal gland, and this catecholamines is eventually going to cause increased heart rate. Wait. You told you cannot rise and increase in heart rate when there is hypoxia. But it's happening. The baby is fearing. But now, the baby is slightly smart in that way. See, the increased heart rate will obviously want more oxygen. So, these catecholamines also causes vasoconstriction of the lacunae and the sinuses that has been formed in the placenta, and tries to push those blood into the fetal circulation, thereby pushing those remaining oxygen in that supply into the fetal circulation. So the blood from the uterine sinuses or uteroplacental sinuses or the lacunae enter into the fetus, thereby supporting, giving oxygen for the increased heart rate. Then the third step also that happens with catecholamines is breakdown of glycogen. So when glycogen breaks down, there will be glucose. So for increased heart rate, you need glucose. For utilization, so glucose is also given. But you also know there is working in a hypoxic environment still. And this hypoxic environment, this glucose is probably going to get metabolized in an anaerobic mechanism, because of which there will be formation of lactic acid. So till this phase, till the baby's heart rate increases, if you recover the baby, how do you recover the baby? Simple. If there is a uterine contraction, to remove the uterine contraction, you can just give IV fluid that will wash out anything that causes uterine contraction, like oxytocin or misoprostol, whatever you had given, which will remove the uterine contraction. Second, you give oxygen, you give intermittent nasal oxygenation, and because of this glycogen breakdown, there will be lactic acid formation. And to correct this acidosis, you can give soda bicarb. Though there are not much randomized control trial on soda bicarb, but still, this is the treatment that we usually give, right? And we make the woman in left lateral position so that the aortic compression is also relieved, and the IVC compression is relieved, and the blood flow to the mother's heart increases, the baby's uterus increases, and eventually to the baby increases. So we do left lateral position, we do IV fluid, we give oxygen, we give sodium. So you understand the reason why we do everything. IV fluid for stress, oxygen for oxygen, lactic acid ke liye we give soda bicarb, and we also give lateral position that increases. So till this phase is called compensation. So this is how the baby compensates the stress. This is called compensatory mechanism. So in compensatory mechanism, the baby releases catecholamines and it tries to conserve, conserve its blood supply to heart, brain. And I have already told we will not discuss kidney in the pathophysiology of acute hypoxia, because the kidney pathophysiology, kidney is usually affected as a chronic hypoxia, and as a consequence of chronic hypoxia, because in one day the urine output is not going to change and it is not going to manifest in amniotic fluid index. So when there is a chronic hypoxia, chronically the baby is having less blood supply, then the baby might have oligohydramnios, which will be a feature of chronic hypoxia. And in the subset of chronic hypoxia, onset of acute hypoxia is even more serious. So this we will deal with chronic hypoxia, and this will manifest as oligo, and we will deal with in later part where we deal with chronic hypoxia and acute on chronic hypoxia. And you already know a person who is starving so much, if you make him do 100-meter run race, he'll collapse immediately. So that's why we all should remember, when we work with oligo, we walk on a double-edged sword. We walk very carefully. Understood? So now, this is the compensatory mechanism. You give the treatment, the baby returns back to normal, and you take decision according to the status of the labor. Right? If the baby is completely dilated at this phase, I think you can deliver the patient. Again, it depends on a lot of factors, on mother, fetus, and patient condition. So now, if the stress further persists, if I don't treat it, or despite treating the stress is not being able to be removed, if the stress persists, then the baby enters into a phase of decompensation. So in decompensation, what happens is, there is no enough oxygen for the baby, because the baby is already in complete hypoxia and it has already entered into acidosis, and this has led to damage to the brain, and especially damage to the autonomic nervous system of the brain will affect the beat to beat variability. So for the small stresses that the baby should respond ideally, there are biochemically a lot of stress that happens in the baby's body, and the baby responds to every small stress by changing its heart rate slightly up and down for each beat. So that is manifested as beat to beat variability, and this beat to beat variability is no more important, because it's no more a factor, because the brain is already affected, so it cannot adjust itself for minute stresses. So there will be loss of beat to beat variability, which will be manifested as a flatline NST. And we already know in the previous step, there was an increased heart rate, so there will be a baseline tachycardia along with a flatline NST. This means the baby is already in decompensated state, which means the baby is already having some amount of brain injury, and you know in postnatal you will have a perinatal asphyxia in such baby, and immediate termination through cesarean section is the treatment of choice in these patients, and any amount of treatment is not going to reverse these conditions because it's already entered into decompensation. The brain is already damaged. The brain is damaged. Now, still, the stress persists. If the stress persists, then is the worrisome part. Now, the lactic acid has already accumulated too much, and this lactic acid inhibits myocardium, and this will decrease the heart rate. Now tell me, the heart rate was around 180 before. Now the heart rate comes to 140 with a flat line. Now tell me, anybody who sees a normal NST with 140 heart line, like 140 is a normal heart rate. Nothing to worry. Just the beat to beat has gone. There is no issue. The baseline is normal. When the first rate is normal, then why do we worry? No. You have lost something that has happened before. So a baby who had a baseline of 180 dropped to a baseline of 140, and it is not having beat to beat variability. It is already having perinatal asphyxia, and if you leave further, it will come to 120, it will come to 80, it will come to 60. So it will form this pattern. This is step ladder pattern to death. So that's how a baby dies in fetal hypoxia. So just because you got a normal heart rate does not mean the baby is good. So I hope you are understanding the intricacies of how the changes in fetal heart rate actually manifests through NST, and how do we pick up the meaning of just fetal heart rate does not carry any meaning, and what is the reason why you need to pull out NST, and how the NST progresses throughout the pregnancy. And this will be your baseline video for coming back again and again for understanding the intricate physiologies on why and how these changes actually set in biochemical way. So as always, keep learning, keep teaching, let every baby counts.